Thank you, Chairman. Sorry. And I'd like to say thanks to all organizing committee members. I'm very happy to share the information what I learned from ASHRAE meetings. Okay, fertility preservation is a hot issue nowadays. So there's so many articles were presented at the ASHRAE meetings. The organizing committee selected 6 articles among them. The first one, aromatase inhibitor plus GnRH agonist in treatment of patients with ovarian endometriosis recurrence after surgery by Scalpellini. And second topic is ovarian response among young reproductive age women undergoing fertility preservation compared with healthy oocyte donors. And time of ovarian stimulation in patients prior to chemo or radiotherapy after analysis of 674 stimulations by Meyer. And fertility preservation in women with ovarian and lung cancer, dysregulation in gene expression profile of cumulus cell by also from Pranks. And there were 2 invited lectures about the ovarian transplantation and uterine transplantation. We tried to summarize it. First topic is aromatase inhibitor plus GnRH agonist in treatment of patients with ovarian endometriosis recurrence after surgery by Scalpellini from Italy. As you know, endometriosis is a chronic condition affecting around 10% of women of reproductive age. Unfortunately, it recurs in about 50% of cases after surgery. The surgical treatment of ovarian endometrioma affects ovarian dissolve as well alone. So the aim of study was to determine if medical treatment with aromatase inhibitor, anastrozole, plus GnRH analog leupride is an effective therapy in women with recurrent of ovarian endometriosis after previous surgery. As you know, aromatase is expressed in ectopic endometrium and has the role for production of local estradiol. So can we use the aromatase inhibitor in endometriosis patients? They can answer. This is a randomized control study, and 59 women with recurrence of ovarian endometriomas were enrolled and assigned to 2 groups by computer-generated sequence. As the study group, 31 women treated for 6 months with anastrozole 1 milligram per day plus leupride 3.75 milligram per month. As the control group, 28 women were treated for 6 months with leupride only. Primary outcome were time of endometriomas disappearance and IVF outcome. The time of endometrioma disappearance in combined therapy group was 2.8 months. It was significantly shorter than the combined group, shorter than the control group. And also, the pregnancy rate for IVF in combined group was 55%. However, in control group, 21%, it was 21%. So the pregnancy rate of IVF was significantly higher with combined therapy group. They conclude that aromatase inhibitor plus GnRH agonist may be useful in the treatment of women with recurrent ovarian endometriomas in order to avoid further surgery and preserve ovarian dissolve and improve IVF outcomes. However, these data need to be validated in a large group of patients. As a clinical implication, we can think that aromatase inhibitor plus GnRH agonist therapy seems to be a promising second-line treatment in patients with endometriomas recurrence, especially for ovarian lesion. Second topic is ovarian response among young reproductive aged women undergoing fertility preservation compared with healthy oocyte donors by Goldman from USA. Chemotherapy or radiotherapy frequently render young reproductive aged women infertile with greatly diminished or absent ovarian function. Female survivors of childhood and adolescent cancer are significantly more likely to experience clinical infertility compared with their siblings. The advent of oocyte cryopreservation technique has provided one option for preserving a young woman's fertility. However, few data exist regarding fertility preservation outcomes in early pubescent and adolescent girls. So the authors evaluate how ovarian response to stimulation differs among young women under age 25 undergoing oocyte cryopreservation or medically indicated fertility preservation compared with healthy oocyte donors. This is a retrospective cohort study. Only the first cycle of each subject were included. 60 young adults and adolescents under age 25 years undergone oocyte cryopreservation for various medical indications were compared with 90 healthy oocyte donors in the same age group. The youngest patient in this group was 12. Total gonadotropin dose in fertility preservation group was 3,000. It was slightly greater than the control group. And also, the starting dose of gonadotropin was greater for cryopreserved group. The total number of oocytes in each group were not different. However, the number of M2 oocytes was slightly lower in the cryopreserved group. Once again, 84% of oocytes were M2 oocytes in control group. However, 76% of oocytes was M2 oocytes. So the percentage of retrieved M2 oocytes was slightly lower in cryopreserved group. They conclude that controlled ovarian stimulation was effective for all young women undergoing oocyte cryopreservation, and all patients have mature oocyte cryopreserved for future attempts at pregnancy. However, young pubertal and adolescent patients undergoing oocyte cryopreservation have slightly diminished responses to gonadotropin. I think they do better check up the subgroup analysis regarding the early pubescent girl, because the range of age of cryopreservation group was 12 to 25. So early pubescent girl, the data from the early pubescent girl may make the influence on the results. Anyway, we can think that young pubertal and adolescent patients undergoing fertility preservation for medical indication can safely achieve adequate, although perhaps slightly diminished, ovarian responses to gonadotropins. Next topic is timing of ovarian stimulation in patients prior to chemo or radiotherapy by Goldmeyer from Germany. Fertility preservation procedures should be performed as fast as possible in order not to postpone oncologic therapy. Initiation of ovarian stimulation has been shown to be possible at any time of menstrual cycles as part of fertility preservation procedures. However, data about the efficacy of stimulation initiated in the middle-late and luteal phase of the cycles are limited. So authors compared the number of fertilized oocytes and the dosage of gonadotropin between the early proliferative group and middle-late proliferative or luteal phase group. 674 women from 99 centers were included and grouped into early proliferative, mid and late proliferative, and luteal phase. As you can see, the number of fertilized oocytes and zygotes were not different in each group. However, the duration of stimulation is much longer in luteal phase group, and the gonadotropin dose is much higher in luteal phase group. So they conclude that the number of fertilized oocytes and zygotes was not significantly different if the stimulation was initiated during different phase of the menstrual cycle. However, the dosage of gonadotropin used was significantly higher if stimulation was started in the middle-late proliferative and luteal phase of the menstrual cycle. So we can think that ovarian stimulation can be started as soon as possible, irrespective of the menstrual cycle, to avoid delay of chemotherapy or radiotherapy. However, the dosage of stimulation should be adapted according to the menstrual phase in which stimulation is initiated. Next topic is fertility preservation of oocyte for women with ovarian cancer or lung cancers, dysregulation in gene expression profile of cumulus cells by Aso from France. The transcriptional profile of human cumulus cells are known. However, data are lacking about the molecular signature of cumulus cells from women with cancer included for fertility preservation before cancer treatment. The aim of study was to compare the gene expression patterns of cumulus cells isolated from healthy women and patients with ovarian cancer or lung cancer, including a fertility preservation program. The study included 16 cumulus cells from healthy women and 16 cumulus cells from lung cancer patients or ovarian cancer patients for fertility preservation. Cumulus cells from M2 oocytes were analyzed individually using whole genome microarrays. Many genes related to HER2 signaling were differentially expressed in two groups. These gene products may elevate the risk for breast cancer, endometrial cancer, and the other gynecologic cancers. And also, mRNA transcripts of factors controlling cell cycle and proliferation were differentially expressed in two groups. As you can see, cyclin E2 and cyclin D3 were higher in cancer group. Dysregulated expression of these genes may contribute to increased cell division. CD200 and CD24 were downregulated in cancer group. Dysregulated expression of these genes may contribute to reduced oocyte developmental competence. And also, the majority of genes related to the TGF-beta signaling cascade were downregulated in cancer group. TGF-beta1, SMAD3, and EGFR were downregulated in cancer group. Dysregulation in the TGF-beta signaling cascade may contribute to reduced oocyte developmental competence in patients with ovarian and lung cancer, even before cancer treatment. Here's conclusion. Comparing the cumulus cells from healthy women, the gene expression profile of cumulus cells isolated from patients with ovarian or lung cancer, present alteration that could lead to a reduction in oocyte competence. This study opened a new perspective for understanding the impact of ovarian and lung cancer on fertility preservation, even before chemo or radiotherapy began. Here's another polling question. Which of following are high risk for transfer malignant cells with transplanted ovarian tissue? Number 1, leukemia. Number 2, breast cancer. Number 3, Williams tumor. Number 4, colon cancer. Number 5, squamous cell carcinoma of the cervix. Please push the button. Okay. We can see the answer of the next slide. Okay, move on, please. Okay, there was an invited lecture about the ovarian transplantation by Dr. Dolman from Belgium. There were different cryopreservation options for fertility preservation in cancer patients, including embryo cryopreservation, oocyte cryopreservation, and ovarian tissue cryopreservation. However, cryopreservation of ovarian tissue is the only option available for prepubertal girls and for women who cannot delay the start of chemotherapy. Dr. Dolman examined the evidence relating to ovarian tissue reimplantation. There are two options for ovarian transplantation, such as reimplantation of ovarian tissue fragments or transplanting isolated follicles. After cortical biopsy, we make the ovarian fragments and perform the avascular transplantation. More than 60 cases of orthotophic reimplantation of frozen soul ovarian tissue fragments have been reported to date, and 30 live births have been published. However, in this procedure, we have some risk for transmission of malignant cells. So we can avoid the risk like this after isolating follicles, make the artificial ovary and graft it. In 30 published articles, 38 live births have been reported following orthotophic reimplantation of frozen soul ovarian tissues. Slow pleating technique has been used. Most common graft site is ovarian medulla, and spontaneous pregnancy were obtained around 50%. The pregnancy rate associated with orthotophic reimplantation of frozen soul ovarian tissue fragments is around 22%. However, there is a risk of transporting malignant cells with transplanted frozen soul ovarian tissue, especially leukemia, neuroblastoma, and Burkitt's lymphoma. So reimplanting of isolated follicles instead of reimplanting ovarian tissue fragments may avoid the transmission of malignant cells. Before cancer treatment, we get the ovarian tissue and freeze it. After cancer treatment, ovarian tissue are thawing, follicles are isolated by using enzyme, and then the follicles are put into a stromal scaffold containing fibrin and fresh isolated ovarian cells from the cured patient. Finally, the artificial reconstructed ovary is clinically grafted. They conclude that more than 60 cases of orthotophic reimplantation of frozen soul ovarian tissue has been reported to date, and reports of 30 live births have been published, yielding a pregnancy rate of more than 22%. However, there is a risk of transferring malignant cells with transplanted frozen soul ovarian tissue. So reimplanting of isolated follicles may avoid the transmission of malignant cells. My last topic is about the uterine transplantation by Brunstrom from Sweden. Around 1 out of 500 of women of reproductive age suffered from absolute uterine infertility. Gestational surrogacy and biological adoption is the only current means to acquired motherhood. Absolute uterine infertility are including the patient with MRKH and patients through hysterectomy due to cervical cancer, myoma, peripartum hysterectomy, and also patients with non-functional uterus, such as Asherman syndrome, myoma, and uterine malformation. The Dr. Brunstrom and colleague examined the feasibility of uterine transplantation in case series of 9 women with absolute uterine infertility. This human evaluation comes after extensive research in rodents, pigs, sheep, and non-human primates. Most recipients were MRKH patients, and majority of the donors were mother to the recipient. Age of recipient were 27 to 28 years old. In 8 MRKH patients, their vagina was made by self-dilated, therapy-dilated, and skin graft. For harvesting the uterus, the surgery involved the isolation of the uterus with long vascular pedicles of the uterine arteries and vein and part of internal iliac artery and veins. The one admitted to the ICU and hospital stay was 6 days. The surgery takes just 10 to 13 hours. Recipient surgery generally lasted 5 to 6 hours with no stay in the ICU. The external iliac artery and vein were mobilized bilaterally. The vaginal cuff was separated from the blood and ureters. The uterus then brought into the pelvis. Bilateral end-to-side anastomosis was accomplished between vessels of graft and external iliacs. After re-establishing blood flow, the vaginal rim of the graft uterus was sutured to the vaginal vault. The graft was fixed bilaterally to the round cardinal and uterosacral ligament. An extensive leaf of bladder peritoneum of the graft was sutured on the top of the bladder for extrastructural support. No ICU was needed, and hospital stay was 5 to 7 days. After transplantation, 2 patients suffered hysterectomy due to a bilateral arterial thrombosis and 1 case of infection. However, in 7 patients, regular menses occurred from the 2nd month. Patients received a low-dose immunosuppression protocol. After 6 months, 7 patients were only on a low-dose tacrolimus. After 14 to 20 months, single embryo transfers were started in 7 patients. These researchers have shown the feasibility of human uterine transplantation from live donor with low-dose immunosuppression protocol. Pregnancy results from this cohort are expected in late 2014 and 2015. Who knows, in the future, uterine plantation could be a feasible option for women with absolute uterine infertility. In summary, Goldman reported young pubertal and adolescent patients undergoing fertility preservation can safely achieve adequate, although perhaps slight diminished ovarian responses to gonadotropin. And ovarian stimulation can be started as soon as possible, irrespective of the menstrual phase of the cycle, to avoid delayed chemotherapy or radiotherapy. However, the dosage of stimulation should be adapted according to the menstrual phases in which stimulation is initiated. Gene expression profile of cumulus cells isolated from patients with ovarian and lung cancer present alternation that could lead to reduction in oocyte competence. In patients with recurrent endometriosis, aromatase inhibitor plus GnRH agonist therapy seems to be a feasible second-line treatment. Fertility preservation by ovarian tissue cryopreservation is now a real possibility for patients whose gonadal function is threatened by radiotherapy or chemotherapy. Dr. Brunstrom have shown the feasibility of human uterine transplantation from live donor coupled with low-dose immunosuppression protocol.